this is for hip abduction. Now the difference with this compared to your regular positioning is we actually have them flex the lower leg and have the top leg extended. We're going to flex this one, this one back. You wear that square, use that square bolster the same way you would, but then you have them in a more anatomically neutral position, at least for this leg side of the body. And that's the only important thing, is you want to try to make sure they're not twisted in this assessment, because that could offset the assessment. For anything here, when we get to the other real important one, which is going to be hip hyperextension, that's the one that's usually the most dysfunctional. The one where they lay prone and it's lifting the leg off the table, it's checking for how is the low back functioning relative to their glutes. And usually the low back is activating too much and the glutes are not activating enough. And that's a common thing that you'll just see forever. Same thing with the knee extension one. It's just very common that medialis is underperforming and lateralis is way too strong and tight for a variety of unknown reasons, but it's just a pattern that people fall into. Here, it's the same thing ultimately, that the low back should be secondary, if not third in line. It should be third in line, always. But for your palpation readings, it's going to be, is it low back or is it glutes? That's my shortcut for you. The other palpation, the other muscle that the book is telling you to palpate is tensor fasciolata, but to just simplify things, all you have to do is distinguish where the greater trochanter is and be just above it. Now we are in gluteus medius. So just superior to the greater trochanter is gluteus medius. Here, I gotta just be superior to the iliac crest, right there, down into the low back. The tough part here is the sequence as it's laid out is almost always relative to quadratus lumborum, which is a very, very deep muscle. Now it's deep. Where it attaches is on to the upper edge, the iliac crest, comes over, attaches onto the lower rib, so it actually can get affected related to breathing. But it's all about lateral flexion. The thing here is that it's not too different to what I was talking about with thinking about how knee extension is different if it's unloaded versus loaded in the kinetic chain, right? So it's a closed chain versus an open chain. The hip, because I can do hip abduction, but with hip abduction, if I go high enough, eventually the pelvis has to shift too, and I end up laterally flexing at the spine as well, even though I keep my body and head oriented with the horizon, compared to going like that, right? So this is talking about if a person's doing the outward kick action, but that's not too different from doing this, having to just catch yourself, right? You get off to the side, there's a stumble, all those kinds of things. Abduction, adduction, in a simplistic way of thinking about it, are your balance muscles. So if somebody has balance issues, this is worth looking at. I'll show a little bit of a easier shortcut of how to just reduce the tension of low back stuff here in this position. But if somebody had low back dysfunction, and particularly related to balance issues, this is a really good one to look at and go to. You have to, the challenge is, and the annoying part for people is having to just put the bolster there. That's not that big of a deal. Okay. So I have to palpate here, here, and then it's just lifting the leg up off the bolster a little bit. Good. Very much easier to explain that. If tensor fasciolata or the hip flexors were too strong, the one thing that would happen here is the leg would kick forward first. The hip would inadvertently flex, and then they would abduct. And what that would tell you is that the hip flexors are way too tight. And the way the book is laid out, it would tell you the tensor fasciae lata is way too short. Here she didn't do that. Lift again. And sure enough, the low back kicks on first. So, can we imagine what the goal is here? It's going to be inhibitory pressure plus the movement. All I got to do, find a way to get into this space. The challenge I have with the how this is typically taught is I don't think very often we're actually deep enough to truly be on quadratus lumborum. I think sometimes it is more like the obliques and more superficial structures. Because I can't push deeper than the client's tolerance, right? And I'm already sensing that that's feeling tight. So I don't think I'm too QL. I think I'm more than the obliques. A little lift, hold. And maybe, this is a big maybe, and back down nice and easy. If I get the obliques to calm down relative to this action, they can function better as core muscles. And that's where I send my positive intention. Prayer. And again, a little lift. And down nice and slow. Slight change of position, just chasing areas that feel more tight. Are we doing good? Okay. More pressure, is that about right?
That's about right.
Okay, a little lift. And down, nice and easy. And just because it's actually helping. This is a case where I truly feel myself sinking further and further in. The other important part, and again, is watching for and feeling how smooth the motion is. And relax. In many cases, when you're doing the fancy muscle energy techniques, even if when it's not firing pattern related, I really encourage to not worry quite as much about the tone of what you're pushing on versus the efficiency of the movement you're having the client do. If the movement gets more efficient, you've done something. Now, that's one way to interface with the low back. I get it, that the challenge of having to put the leg under a bolster again and all that. So if that doesn't seem to be the issue, here is a touch of a shortcut. We're going to switch the legs back to how you would normally have it. And you guys have seen this some in the past, but there's a co-contraction that occurs here from this side adductors to the opposite side lateral flexors abductors, okay? Yep, and that's a very easy action to do. What I like about this, compared to having a person lift their leg in prone, is that can be difficult. That's kind of a lot of stress on the low back area. So if we have somebody that's more frail, or if there's nerve impingement, or if there's spinal fusion, blah, 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 I'm worried about the stress it would put on the spine or the SI joint or something. I limit having a person do the motion in that orientation. Pretty much I tended towards, especially if I felt more cautious, I wouldn't do it in prone at all. But this is a great way to activate anything here. The body can't help it. It's designed well related to this. But having a person actively move this leg is not causing any specific stress to the spine. It's just causing a co-contraction. So I really go to this as your main shortcut for doing a muscle energy technique on low back everything. That is the safest and by far the most effective. One, you can get the most leverage here in this position. You're not reaching to the middle of the table, all that stuff. I know I've shown it a few times in like demos and everything, but I just really want to reiterate, you got somebody with a low back thing, this is your best go-to if you're truly going to throw an MET at it. All right, and all they got to do, it doesn't have to be big, is just start to lift their leg up off the table. It doesn't have to be any bigger than that. It can be even smaller than that. And then I can chase where the hypertonic tissue tends to be. Does it feel more lateral, like it's obliques, quadratus lumborum? Do I feel something? Does it elicit the symptom? Or is it further back? And as we go further and further back, we suddenly are going from this place where these diagrams don't do the best job. But you can see how I'm pushing here. Look at that seam, how your lats come down and meet the lumbar dorsal fascia, how your obliques come over and meet that same line. That travels deep and actually interfaces with psoas, quadratus lumborum, all the way down to your paraspinal and rectus spinae muscles. So getting that seam and line more pliable affects basically everything, including psoas. I would tell you to start with freeing this up before really trying to do like psoas stretches and releases and stuff like that. But look, I can keep going more and more posterior, traveling from here. That's probably supposed to be, I know that's QL. So here, I can be denting here. This could be affecting breathing, all that. If I just keep my angle going more and more posterior, I can get my elbow set right to the SI joint, or as close to it as you can get. And even applying pressure here and having them activate the opposite adductors, so it works really good. It's just the one that I can tell you, it's a low back everything, and then you just chase it. I tend to start very lateral, like I'm a magician cutting them right in half. And that's that 90-degree contact versus changing my angle more and more and more until finally I'm back here. But you could find a million spots or one particular one, but you get to make it be just a trial and error experience. All right, we're gonna do a little bit of all of it. Her whole back's gonna be very much reduced in tone. So a little lift, good, hold, big breath, and slowly exhale and let the leg down. See how I couple the breathing with it? Now that one we've already worked on. So now I'm just gonna go more posterior and increase my elbow angle. That's all that I had to do. Oops. Little, she didn't slide off. So. A little lift. And down nice and easy. And starting out, I really encourage you asking the client now, as I work through here, tell me if we find something that really jumps out at you. I keep it pretty ambiguous like that. Any of that feeling? Or is it more the lateral spot?
Lateral,
Yeah. That's all seeming okay.
Mm.
Very good too.
A little bit.
So follow and a little lift. Nice and easy down. I have a little nuance here. It's like grab onto the traps. Distract them a little bit with a good. Or there, the spot I was just on.
That one there.
Okay, there we go. So more L4, L5. Probably not, it's just that. The rectus spinae. Okay, again. And down. And one more. And down. There. A little easier.
Mm.
Good. I felt it soften. The action was easier, all of it. The biggest reason why I want to reinforce this is that the erector spinae of the lumbar spine will be the place, actually I phrased that wrong, is the place that massage therapists struggle with getting adequate pressure for people that want lots of pressure. Because in prone, it's at the center of the table, and you're trying to get yourself into an awkward orientation. Now I'm going to show how I accomplish that, but ultimately I would say this is more ergonomically and body mechanics sound. To get yourself set in a position where you can really get yourself set, they can roll back into you a little bit, and get the bolster, the pillow, everything set where and you just don't have to be reaching, and all you have to do is start here. Wow. And it's just one of those where if I have a big one to showcase to you for interventions, please remember, even if you don't use sideline a ton, you could turn a person on their side real quick, do this over the sheet, flip them on the other side, over the sheet, go to supine. But don't hurt yourself and waste your time working on the low back and prone if it's not feeling efficient for you. And it just isn't, because you can't get lateral with it, right? So let me balance her out real quick. Quick assessment time. Step the lift her leg up. Oh, that low back set. This might be worth it. Does anybody want to palpate? Well, you'll be palpating each other, but you want to palpate? Yeah. This is a good one. All right, there, and you can't be too delicate. And then here, you're looking for the greater trochanter, then just above it, okay? And low lift.
Oh yeah.
Just, when it's wrong, boy, does it jump out strong, right? So what's nice too then is I have a clear sense, like you felt where that was, like it's lateral and a little bit deep. It's like, okay, I gotta find that, and this is the thing with your forearms. If you have palpate with your fingers, then just keep your fingers there, put your forearm right where they are, and swap them out. That's an angry spot. Now I'm gonna distract with some shoulder. So a little lift. They get a little better. Mm-hmm. Yeah. So remember, when they're activating, it actually feels better. So incorporating METs is kindness for a variety of reasons, including how it feels. Just let it go. You give a person a sense of control, right? Rather than just saying, you know, I'm just gonna bash on this until it tenderizes. Like, that's not very nice. Okay, get a little lift. Slowly down. Okay, I'm feeling things shift a little bit. Now I'm gonna incorporate here and essentially anywhere. Sprinkling in the breath is a nice added piece, whether it be for scapulas or anything low back. So little lift, okay, hold, big breath, and all the way out and let it down, nice and slow. Because these structures can get, believe me, if you've had low back stuff, you know how much it affects your breathing. It's like your muscles turn it into a back brace for a girl, right? So, or set. And so it's bracing and control is trying to protect the spine. But that means that also those muscles are not lengthening for appropriate belly breathing. So there's ways to kind of, and if one, it doesn't matter what started it, it could be bad breathing, cause the low back tension. Again. Yep. And slow it back down. And incorporate the breathing that time. But if you're in pain, you're stressed. That's going to tend toward more sympathetic upper chest related breathing patterns. Okay, again, left. And that was much more efficient. Big breath. And all the way out. Yeah. Good. Now that action is only really associated with the lateral sides of the body. So frontal plane action. So after that, go to the other orientation. And I gotta swap the legs. One option with these things regarding like how it could interface in your protocols, you could wait to do some of these until after the session's done, just over calling. It's like timing and stuff becomes an issue, but you know, having to swap the bolster around and everything, there's no reason why you couldn't just like assess it during the session and then afterwards save that 5 or 10 minutes and just do it real quick over clothing on the table or in a separate room. That's where the sheet actually helps you. That's the vinyl on the vinyl. It's causing the slip there. How's that doing?
Good.
Yeah, it doesn't seem. Comparing and contrasting the this side of her low back to the other. There was already a difference, but now it's like, that doesn't feel. So okay, that one was very isolated. This side of her low back was more lateral. Let's call it QL. The other one had some QL, but also rectus spinae. That's where I could just be trying to kind of figure out the blueprint of what's going on here, right?